Good afternoon once more, dear network, and thank you for joining us on today's ECHO session. My name is David Singini. I work for CIDAS under the USAID funded project called TB Loan. And today's session is about tuberculosis, where we're going to be looking at TB preventive therapy, as well as updates from the newest guidelines for TB case management. So this session is going to be done by none other than the TB and the National TB and Leprosy Program Manager. That's Dr. Patrick Saili Lungu, who has joined the call. And as the discussions go on, we're going to have a panel of experts, which comprises Dr. Rehab Chimzizi from NTP. We also have Dr. Nancy Chandakasese from USAID Zambia. We will have Dr. Monde Muyoyeta from CIDAS, Director TB Programs. We have Dr. Linus Mwinga from CDC, and we also have Dr. Lilongwe Muti from CIDAS, and several other experts that have contributed to the development of the guidelines and that play various roles in the TB program. So at this juncture, colleagues, allow me to invite Dr. Patrick Lungu to introduce himself and make any declarations if there are any, and we'll get into the session for today. Dr. Lungu.
Yeah, thank you. Good afternoon, everyone. As introduced by the session chairperson, I'm Dr. Patrick Saili Lungu, the National TB and Leprosy Program Manager here at the Ministry of Health. I'm happy to share with you the topic of the day, which is TB preventive therapy. And I'm happy that we have a number of experts to discuss the subject matter. So mainly, Chair, I hope I'm audible enough. Can you confirm?
Yes, Doc, we can hear you loud and clear.
Good. So just also to say that with me here is Dr. Rehab Chimzizi, who is a technical advisor to the TB program. So he's equally on the panel for this session. So I think for this session, we'll focus much more on what are the gaps with regards to TPT. As a country, in terms of taking up TPT, mainly people living with HIV, but there are other populations that really deserve and qualify for TB preventive therapy. So just to qualify that I have no disclosures in terms of conflicting interests in this presentation. Next slide. Yeah, so this slide just helps us to understand where we are with regard to mortality attributable to TB. You will see that around 2000, or rather before the year 2000, we had a huge proportion or huge TB mortality rate. It's been declining steadily. You could see that from 2003 to about 2017, it was more of a very slow decline in TB mortality. But of great interest is the orange line. You see that starting from 2018, 2020, going to 2020, there's a huge decline in terms of reduction in TB mortality. This period is quite interesting in the sense that it coincides to the period when we started the scale-up of TPT. There are a number of reasons that can be attributable to this, but I'd like just to remind everyone that TPT, not only does it prevent TB, but equally prevents severe forms of TB, which could lead to mortality. So partly, there's a possibility that while HIV patients contracted TB, they did not have life-threatening forms of TB, hence that reduction. But of course, we also give credit to good ART management We have seen a lot of people living with HIV having viral suppression. So besides that, ART has had a huge impact on reduction of mortality in people living with HIV. Next slide. Yeah, here's an interesting one. You see that the gray line is crisscrossing the orange line. So you see the blue line is highlighting to us a decline in incidence, TB incidence. You can see that it's a steady decline. But what we are seeing from here is that around 2018, going to 2020, we have a sharper decline in the incidence of TB among people living with HIV. But what we are seeing is an upward swing in TB among the HIV negative individuals. And you can see that as a country, we have not been providing TPT to people who are HIV negative on a large scale. So this is a population of great interest, and I think we'll talk much more about this population. Next slide. So just to share with you that your efforts are yielding results. Zambia was noted at a higher level, or rather at a global level, as one of the countries with good TPT completion. If you look at the countries with the highest TPT completion rate, in terms of proportion, Zambia has the highest. Of course, in absolute numbers, we are not. South Africa has higher numbers. In terms of proportion, I think we are next to Tanzania, who are at least at 90% TPT completion. This is of the FY20. So certainly things have shifted, but just to indicate that your efforts are yielding desirable results, and we commend you for these efforts with regard to TPT. Next slide. Yeah, so this slide is quite interesting. Just to share with everyone that as of end of Q1, Zambia has provided TPT to at least 1 million individuals. And these are mainly people living with HIV. So this is great progress. So out of the 1.1 individuals who are currently on ART, at least over 1 million have had exposure to TPT once in their lifetime. And this is from the period between 2018 and 2022, end of Q2. So we commend you again for the great effort, but we still have a population yet to be diagnosed with HIV and also yet to be reached with TPT. And that's the one in orange. At least about 400,000 needs to be reached for us to say, yes, we've covered almost everyone. So this is going to be a going concern that we need to reach all persons living with HIV with at least TPT, unless there's a contraindication, and contraindication being having active TB disease or having hepatic injury of which TPT may be a threat in that particular individual, or having had a prior reaction to TPT drugs. So by and large, TPT is safe, but of course there are certain populations who may have some contraindications to TPT based on their pre-existing conditions, such as the ones I mentioned, e.g. patients with chronic liver disease. So colleagues, with persons living with HIV, the guidance and the approach is to sustain the momentum. So let's sustain the momentum and ensure all persons living with HIV who have been commenced on TPT complete TPT, and this good progress should not, we should not slacken on the great milestones that we have achieved. Next slide. So we did, this is again, just highlighting where each of the provinces is or are with regard to TPT coverage as of June 2022. And the numbers we are seeing are in absolute percentage. So you see provinces like Luapula and Eastern Province going above the mark of the estimated people living with HIV. So these are issues to deal with numbers of persons living with HIV. So there could have been a miscalculation on persons. If you note, there are certain individuals who have crossed over in terms of the provinces, may have moved from Lusaka or whichever part of the country to these provinces. So you see I've put a trend line in orange, and the orange line signifies at least provinces who are above 80%. So we see that 7 out of 10 provinces are at least above 80% mark in terms of coverage of persons living with HIV. We only have 3 provinces that are below the 80th percentile, and these are Lusaka, Northwestern, and Western Province. Of course, we would like to see that all provinces move into the brackets above 90%, if not 95%. I think that should be the target. So with Lusaka, there is an element of data issue, but equally there's an element of a proportion of patients who are coming from the private sector or who are accessing ART in the private sector who are not reached with TPT. So if there are colleagues from Lusaka province on this platform, the guidance from the national level is that let's collaborate with the private institutions and start to advance the agenda of TPT. Remember, even persons who are in the private sector or accessing ART in the private sector tend to have TB. And it's an issue that speaks to the aspects of medical ethics, equity. So the persons who are accessing ART in the private sector should not be disadvantaged because they have chosen to access TPT from the private sectors. So in this regard, I would like just to provide guidance to everyone here that using the existing platforms for ART, let's provide TPT through these. The way we give ART for free of charge is the same mechanism that we should employ and call upon to ensure that the patients who are accessing care in the private sectors access TB prevention therapy. I think that's largely the case for Lusaka. Northwestern, quite a mobile population and vast, covering similarly with Western Province, quite a huge terrain. So it's an issue of picking up deliberate steps and understanding the drivers of the poor performance or the suboptimal performance in these provinces to ensure that we address these inherent and existing bottlenecks. We need to unlock them and remodel the provision of TPT, and we bring about enhanced access. So colleagues, these are the guiding principles. And for the provinces that are above 90, let's sustain the momentum and keep up the trend with regard to TPT. Next slide, Chair. Yeah, so for everyone on the call, this slide builds up to the earlier slides where I was showing that TPT has a huge impact on reducing TB mortality, has a huge impact on reducing TB incidence. This slide just shows us the average, the risk of TB HIV. If you look at the blue line ART coverage, showing the ART coverage going up, the orange line, or the ones with marked orange square boxes, is still showing us the decline in the TB incidence. And the one with diamond-shaped dots, that is showing us the uptake of TPT. So you will see that while ART is going up in the blue line, we are seeing a steady decline in TB HIV. But immediately we start TPT scale up in 2018, we see a corresponding decline in terms of TB HIV, essentially a nosedive. So what this slide tells us that ART is good enough, but with an addition of TPT, you get maximal effect and maximal impact. So for persons living with HIV, for us to reduce TB, we need to employ upon a strategic initiative of providing TPT alongside ART. Are we together? It's a life-saving measure. It's a high-impact TB preventive measure. So we can sufficiently say that between 2018 and 2021, TB HIV co-infection rate has reduced from 60% to 34%, and largely due to the contribution of both ART as well as TPT itself. So this is in itself builds up to the evidence and that TPT works and that it has a positive impact on TB HIV. Next slide, Chairperson.
Right, so we are going to have our first poll question for the session, and it reads, patient X has been in prison for 1 year. He is attending OPD for complaints of headache for 3 days. He reports that he usually has these headaches even before his incarceration. HIV test that's done today, negative. His chest X-ray is normal, and he reports that one of his roommates is on TB treatment based on chest X-ray. What will be the correct action to take on this patient or on patient X? So option A is assure the patient that he cannot be infected with TB since his roommate was diagnosed based on chest X-ray. B, ask patient X to submit sputum for GeneXpert and offer TPT. C, sputum GeneXpert is not indicated since chest X-ray is normal. TPT is not indicated because he has tested negative, HIV negative, hence the risk for TB is low. E, all of the above. So we're going to launch the poll question from this end, and it's going to show primarily the answers. So I'll read through the question again as the poll is showing. Right, I invite you all to take part in the poll. I'll repeat the question as you are giving the poll, the responses to the poll. And remember that this is secret ballot and you don't get to know who has polled and what answer you chose. But we encourage the entire network to take part in the poll, and it will help inform Dr. Lungu on what he should focus on. So the question is, patient X has been in prison for 1 year. He is attending OPD for complaints of headache for 3 days, and he reports that he usually gets these headaches even before his incarceration. HIV test done today is negative. His chest X-ray is normal, and he reports that one of his roommates is on TB treatment based on chest X-ray. What would be the correct action to take on patient X? There we have it, network. That is the question that we're responding to, and the options are showing on your screen now. Choose the single best answer. So Dr. Lungu, I'm sure you are noticing how the voting pattern has been and the inclination of the participants to one or two of the answers. But so far we have about 145 people that have polled out of 293 connections. So I encourage everyone, just give it your attempt to inform the didactic presenter. Right, so just a few more seconds and I will end the poll and allow and show the results. There we have it, network. So 90% of the participants thought B is the correct answer, which says ask the patient X to submit sputum for gene expert and offer TPT. The majority thought that was the correct answer, and we had a few that thought the other options were correct. So I will stop sharing and hand over to Dr. Lungu to speak to this one and take us through the.
Yeah, thank you very much, and happy that I think the message of TB screening in prison, in inmates, has really taken ground. So the ones that did choose B are correct. This is essentially should be a presumptive TB patient, even if the chest X-ray is normal, given that he's had exposure to TB, and while his headaches have been there prior to incarceration, the fact that they have persisted is an individual who can suffer from TB meningitis. So it is important to examine this patient further with a gene expert to exclude active TB disease. And if the gene expert is normal, rather negative, this is a patient to give TB preventive therapy. So the ones that went for B are correct. So I think in a way this slide is being answered. Where are we with TPT in Zambia? You can from the previous slide where I shared that we have done very well with TPT in people living with HIV, exceptionally well, actually, we should say, with honesty. And I'd like just to say that now we are at a point where we are commodity secure with regard to the commodities for treating latent TB infection, and well as the B6. So we should now start to go after other risk population. We've satisfied, we're almost reaching saturation in the most at risk, but we also need to consider other risk populations. As it was highlighted, TB incidence is going up in individuals who are HIV negative, and equally mortality remains high in the HIV negative. So in a nutshell, we can simply say we've done exceptionally well in providing TPT in people living with HIV, but we've left behind the people who are HIV negative, who too are at a huge risk, and not only risk of contracting TB, but equally at risk of mortality. There's another population of interest where we have been exercising a lot of caution, even when they are at risk from living with HIV. And here I'm talking about the population who are the pregnant women. Colleagues, pregnant women are at risk of TB as a result of the immunosuppression brought about by pregnancy. But when they are living with HIV, they have double the risk. So the risk is doubled in pregnant women who are living with HIV. And the TPT uptake in this population has equally been low. And I would also want to just share with everyone that we have been seeing a few cases of MDR in neonates, a few cases of TB neonates. One of the latest cases was a neonate weighing 2.2 kg. Our TB formulations are appropriate for a person who is above 3 kgs. Below 3 kg, we have to start improvising the dosing. So it becomes hugely challenging to treat TB in a neonate. First of all, to diagnose it, it's challenging. Secondly, to treat it. But what that means when a neonate has TB, it simply tells the long story in a very short narrative that we failed to prevent TB when the mother was pregnant. We failed to give TPT. So essentially, there are missed opportunities. It outlines to us that in the course of this child and in the course of that pregnant or mother who's breastfeeding, we missed a number of opportunities to have prevented TB in the mother, and secondly, also to this newborn neonate. So it therefore amplifies that we need to start providing TPT in pregnant women. WHO has made some recommendation on this. I would like also to indicate that there have been enormous concerns of TPT in pregnant women. One being is that pregnant women, when they are provided with TPT, they are at risk of hepatic dysfunction. But there are a number of studies, and even our local experience this far tells us otherwise, that the risks are comparable with the rest of the population. But secondly, there is the issue of the benefits against the risk. So the risks are much lower, the benefits are much more. Yes, of course, hepatic dysfunction can occur in pregnant women, but it can be detected and managed. But the risks are much more. When a pregnant woman contracts TB, there's a huge possibility or huge probability of death and survival. And not only that of a pregnant mother, but equally that of the unborn or the newly born child. So this, therefore, given the risks or given the benefits surpassing the risks, we should therefore provide TPT in the expectant mothers, so that we prevent TB in the two at-risk human beings, the pregnant mother and the child to be born. I'm happy to take on clarifications and questions on this subject matter, but I would like just to guide that it is in our national guidelines for us to provide TPT. If you think or fear that the risk of hepatic dysfunction from TPT is much higher, sorry about that, there's practical steps that you could take. Number one, you could defer TPT till the end of the first trimester. So immediately the pregnant mother gets into the second trimester, provide the TPT. And educate the pregnant mother about signs and symptoms of TB, so that in an event she has TB, before she crosses over to the second trimester, you could pick it up early enough, and you'll be able to provide the therapy in good time. The second option, if you are not comfortable, you could consult the experts, and among the experts are the obstetrician. Among the experts are the HIV specialists as well as the TB specialists. So from both the HIV and TB program, we remain available to provide practical steps and guidance on how to address TPT in pregnant women. Otherwise, all of us should feel safe to provide TPT. So far, the adverse reactions are not any worse in pregnant women than the rest of the population. And the drug of choice for this population is isoniazid. So do not give 3-HP in pregnant women. There hasn't been enough evidence to indicate that it is safe enough. So it's not that there's evidence to indicate that it's not safe, but it's the absence of data. So once there is compelling evidence and data, we have WHO is likely to make recommendation, and possibly the country can make a consideration of that WHO recommendation. So for now, the recommended molecule for TPT in pregnant women is isoniazid, 6 months of isoniazid. Next slide, sir. Next slide. So this just takes us to us understanding again the most at-risk populations, and here we are referring to them as the priority groups. So remember, I already emphasized on people living with HIV being the priority, one of the priority groups. Second are the household contacts of TB patients. And this is inclusive of children and adults. So it's regardless of age. So for as long as you're a household contact of a TB patient, you qualify, or he or she qualifies for TPT. Inmates, by virtue of being in a closed environment and they are being TB patients, they qualify. And even among inmates, the most at risk are those who are sharing the same prison cell with a TB patient. Are we together? Then with regard to minors and ex-minors, because of the dust exposure, they form part of the priority groups. Healthcare workers, time and again, we are in contact with TB patients, and these TB patients, some of them are undiagnosed and untreated. So we are actually we are also form part of the high-risk population. Patients with chronic kidney disease, just to explain to everyone that chronic kidney disease brings about immunosuppression and in itself predisposes one to actually contracting or activating from latent TB to active TB disease. So they should be targeted for TB preventive therapy. Last but not the least, patients who are on long-term steroid therapy or anti-TNF. This includes patients with autoimmune disease such as SLE. I've had patients with SLE with TB before, and we've had some SLE patients provided TPT. I know one rheumatologist, whenever she has a new patient with SLE, she always starts TB preventive therapy. And I think it's a good practice. So I call upon you, the nurses and clinicians, whenever you have patients with SLE, do provide them with TPT, especially if they're on long-term steroids. And for those patients who are on cancer treatment, especially the anti-TNF alpha, these should receive TB preventive therapy. So these are the at-risk population. And just to simplify the guidance is that the guidelines of 2019 still stands, and that besides people living with HIV, let's start providing TPT to these other populations. Are we together? And where you have the means to test for latent TB infection, do the test, especially for the patients in the private sector. But where there is none, just take on the symptom screen, and if possible, include the chest X-ray as part of your evaluation. But where it's not existing, it's not a must be used. Symptom screening is good enough. Next slide.
Right. So thanks, Dr. Lungu. So now we're going to get into the next poll question, which is poll question number 2, and it reads, Mrs. X is on TLD for 2 years. She's attending her first antenatal clinic at 8 weeks gestational age. She has never been treated for TB before. She has no other comorbid conditions. The nurse calls for advice on whether to start TPT. According to the 2019 latent TB infection guidelines, what advice would you give her? Option A, start TPT immediately. Option B, start TPT in the second trimester. Option C, screen for TB now, but start TPT in the second trimester. Part B, or rather D, B and C are correct. So dear network, there we have it. That is the second poll question. I'll be launching it in a second. And I noticed a few people had asked questions related to TPT in pregnancy. So this is your chance. Tell us what you think is the correct answer, and then we'll have Dr. Lungu and the other experts discuss TPT in pregnant women. So the question again, Mrs. X is on TLD for 2 years. She's attending her first antenatal clinic at 8 weeks gestational age. She has never been treated for TB before, and she has no other comorbid conditions. The nurse calls you for advice on whether to start TPT. So according to the 2019 latent TB infection guidelines, what advice would you give her? Option A, start TPT immediately. B, start TPT in the second trimester. C, screen for TB now, but start TPT in the second trimester. D, option B and C are correct. There we have it, network. Very interesting poll indeed. And I'm really looking forward to seeing what people think regarding this poll. So we have about 170 people who have responded to this poll, and we're waiting for a few more. Only 53% have responded so far. And we encourage you all to take part in these polls so that we have a better understanding on the knowledge gap in this particular subject. So I'll give it a few seconds just for us to hit 220 minimum. And just a reminder that these polls are anonymous and we are unable to tell who has polled and what answer they gave. So we encourage you to give us your attempts to inform the subsequent discussion. Right, so the 10 seconds is up. I will end the poll now and display the results so that you could see. Out of 222 people that took part in this poll, we had 39% that thought A was the correct answer, which is start TPT immediately. And we had 30% that thought, C was the correct answer, which says start TPT, which says screen for TB, but start TPT in the second trimester. And we had 27% that thought D was the correct answer, which was B and C were correct. There we have it, network. So I'll stop sharing the results and hand over to Dr. Lungu to take us through this poll and the subsequent slides.
Thank you. With me is Dr. Chimzizi. You will take us through this poll question.
Yeah, so thank you so much. I think compared with the first one, where it was skewed very clear, it was B that time, it was 90%. You'd see this one, the answers actually are split. That requires that probably there's a need for more information. But from our end, the correct answer is D. Because B is correct in such a way that we're talking about this. The pregnant mothers should start TPT in second trimester, but also we know that we can't just go home. Then you find us after first trimester. The most important thing is also to make sure that the mom is screened for TB, so that potentially he may have even active TB. So if he has active TB, that means he has to be treated immediately because you don't have to wait for TB treatment. But if he screen TB negative, this is the case that you really need to, okay, we're going to start you on in the second trimester for TPT. So the correct answer is D. But suffice to say that in the WHO has updated its guidelines, is actually allowed to put a mom who is pregnant even in first trimester. But from the context of Zambia, because that update has not been reflected in our national TPT guidelines until such time when the expert discuss and decide that we are going to change along the WHO guideline that the moms the pregnant mom can start TPT during first trimester. That's when the answer can change. But at a moment, the correct answer is D. So thank you so much, Dr. Lungu. Over to you.
Yeah, thank you. So essentially, we will be updating our TPT guidelines soon enough. And the shift that is likely to happen is that it will be clear that TPT can be started even in the first trimester. So if they have clients on TPT even in the first trimester, let them continue. Certainly we have some data to back that one up, but I thought we should just highlight what our current guidelines do show. Next slide. Yeah, so this just now moves us into what our treatment options for TPT. Currently we have 3 options, but for people living with HIV, we only have 2 options. That is the 3 months of 3-HP, and then the 6H. The 3RH is mainly for children who are HIV negative. Are we together? So 3HP, 6H is for people living with HIV, and 3RH is only for children. So as a country, we've moved with the global trends, and we've absorbed and taken on board what is currently on the market, or what WHO and other global agencies have recommended. So 3HP is available across all the 10 provinces. And once we have enough 3HP, this will be the preferred regimen. There's a likelihood that we will downsize the number of clients who are on 6H. With children, who are HIV negative, 3RH is available. And the beauty about it is that this is a child-friendly formulation. So it is dissolvable in water, and it's got a flavor, so easy for a child who needs TPT to take it. Are we together? So where 3HP, I just wish to clarify this. Where there's no 3HP, please utilize 6H. Otherwise, waiting for 3HP, you end up putting a client at risk of contracting TB and probably dying from that episode of TB. So let's provide the molecules that are readily available. Next slide. Yeah, so I had just about, we only have about 2 take-home messages for you. Number 1 being that TPT together with ART is impacting positively in reducing the burden of TB among people living with HIV. The second one is that TPT is safe in pregnancy and should be provided to the most at-risk population. And these are pregnant women living with HIV, pregnant women who are in contact with a person who has active TB disease. And here we are referring much more to those that are bacteriologically confirmed. So these are our steps. I know we have started providing TPT to contacts of clinically diagnosed, but the most priority for now are those who are contacts of bacteriologically confirmed TB patients. With that, Chair, I stand ready to take on remarks as well as questions and clarifications on the presentation that I've just shared. Over to you, Chairperson.
Thank you so much, Dr. Lungu, for taking us through this concise presentation on TPT and the options that are available in Zambia. At the moment, I will ask the network that those that may have questions or seek clarification regarding what has been presented or anything related to TPT, you could raise your hand or post your question in the chat box, and then we'll have Dr. Lungu and the other subject matter experts on the call respond to the questions. Right, so I've already seen some interesting questions in the chat that came in during the presentation, where one was asking, is 3HP safe in pregnancy? I heard Dr. Lungu had mentioned something about this, But I'll just ask Dr. Chimzizi to just take up that question and maybe provide a bit more clarity on 3HP use in pregnancy. Dr. Chimzizi?
Yeah, so Dr. Lungu covered this very well. So the current guidance is that 3HP, it's currently we're not providing in pregnancy. So the patient that require TPT in pregnancy, definitely the option of choice is 6H, which is 6 months of isoniazid. And Dr. Lungu definitely provided that it doesn't necessarily mean that we're saying that 3HP is unsafe or is safe, but the issue is just the lack of data to support that recommendation. So as an expert in the country, we continue to look for final recommendation that would actually with data to support 3HP in pregnancy. So that's our stand at the moment. As I said, I think the question was, is 3HP safe in pregnancy? So that's the issue that you can take. At the moment, when a pregnant woman from second trimester is eligible for TPT, then the drug of choice is isoniazid for 6 months. Thank you, Dr. Singini.
Thank you so much, Dr. Chimzizi. And just to add on as a reminder, if we remember their network, when DTG-based regimen were introduced in Zambia, we were not giving them to certain populations. And one population was the women of childbearing age. And the reason then was that we didn't have sufficient research or evidence to justify its use, but now we know that it's actually safe. And this is similar to what has been emphasized by the didactic presenter, that we don't have much evidence. And once we get that evidence, further guidance will be given. Right. There's also an interesting conversation that is going on in the chat box regarding what these letters Lungu had put up. We can see here we have 3HP, we have 6H, we have 3RH. Now, we don't want to take it for granted that we all understand what these mean. So I will ask, I've seen Dr. Nancy Chanda has been really explaining what these mean. Maybe Dr. Kasese, for the benefit of those that have not seen your responses, you could just take us through what that means, because I've seen you responded to a few of them. Dr. Kasese?
Thank you. Good afternoon. Yeah, so 3HP actually stands for a newer drug, a TPT regimen that we are using. It is a combination of rifampicin and isoniazid, and the drug is given for 3 months. It's given weekly, so there are 12 doses. The course is 12 doses for 3 months. So the 3 denotes that the treatment is for 3 months, and the H obviously is for the isoniazid, and then the letter P denotes rifampicin. So I think that the discussion that Dr. Lungu was referring to, and I think others have also spoken to in the question is, this is a preferred regimen because it's shorter, it reduces the pill burden, it has less side effects in most patients, so it's well tolerated, and that's why Dr. Lungu said we prefer it for our clients. And just to say that it's not yet, we do not yet have formulations for children under 12 years of age. I think I saw a question also relating to that. So we're not giving it to children under 12 years of age. Thank you.
Right, thank you so much, Dr. Kasese, for that response. Now, I've seen there are 3 hands. We have E. Mungomba, Judith, Dr. Judith and Jackson Mwewa in that order to give us their comments, questions, or contributions. Imungomba.
Thank you very much, Dr. Singini. Thank you, Dr. Lungu, for this nice presentation. I'm Dr. Emmanuel Mungomba. My question is based on the presentation made by Dr. Lungu, where you had mentioned how well we've done with TPT coverage in regard of the saturation we are about to reach. Then on the other hand, you also mentioned how TB HIV co-infection has reduced from 60% to 54%. That was by last year. Now, looking at the saturation we're about to reach and the incidence, the way we are moving towards going to zero TB, we are at 54%. Is there anything we are still missing out in regard of TB HIV co-infection? Has there been any local study done to establish what could be other reasons which are making us to have TB HIV co-infection despite all the measures we've put in place and us reaching almost a saturation level? Thank you.
Right, thank you so much, Dr. Mwomba. That's a very brilliant question. I'll reserve that one for Dr. Lungu, and then I'll ask the next person to ask their question. Dr. Judith.
Thank you very much. I'm Dr. Singini. Good afternoon, network. Then Dr. Lungu and Dr. What's her name again? Sorry about that. The other doctor.
Dr. Chimzizi, Dr. Nancy Chandakasese, Dr. Mondemyoyeta, Dr. Muti, those are our experts.
Thank you very much. I joined late, so I missed this part. First of all, I would like to commend them for doing a very recommendable job as TB experts. They've been with us throughout the time we started this fight against TB. I remember in the early times, TB diagnosis was very difficult to diagnose and the resources were limited. But nevertheless, not to go into so much detail, I would just like to recommend Dr. Lungu for having managed to treat that child. Is it 2-year-old, 2 months, who had TB? Yes, for that one, job well done, Dr. Lungu. We are still limping when it comes to taking care of pediatric clients. I think I will be eager to receive your help and the other experts in our facilities. And then finally, I think probably next time it would be nice to bring somebody from the nutritional part, whereby they can help us with the kinds of food these kinds of patients can eat, which are very cheap and very affordable on the market. Let me not go into details. Thank you very much. Over.
Thank you so much, Dr. Judith, for your contribution towards the subject. And then we have Jackson Mwewa for your comment, question, or contribution.
Good afternoon, network.
Good afternoon. Please go ahead.
Thank you. I just wanted to find out what could be of TPT among the recipients in private sector. Is it that they are refusing the TPT, or is a lack of availability of TPT in those facilities? Thank you.
Right. Thank you so much, Jackson, for your question. So we'll start having those questions responded to. Dr. Lungu, there was a question from Dr. Mungomba regarding the incidence of TB and TB HIV co-infection despite the improvements or the gains that have been done in the HIV program. Your comment on that, Dr. Lungu?
Yeah, thank you very much. Very good questions and practical at the same time. So indeed, there are multiple factors leading to us being where we are. Yeah, but I think we should commend ourselves that we've accelerated the decline, moving away from 60%. We were actually stuck for a number of years at 60% TB HIV co-infection rates. In some settings, it was even going as high as 80%. But with a TPT, we've gone down to at least 34% across the country. So yes, of course, both ART and TPT remove the risk, reduce the risk. But in certain individuals who are currently on ART as well as on TPT, who are failing ART, the risk remains quite very high. So I think it is important to equally ensure that in that patients who are not doing very well on ART, we ensure that we reach full viral suppression and equally remodel some of the risk factors. Some of the risk factors for TB being undernutrition, alcohol, high alcohol misuse. So we need to actually ensure that the aspects of undernutrition is addressed. And then secondly, if there are modifiable risk behaviors such as alcohol, smoking, those equally needs to be remodeled so that we minimize. But by and large, TPT has been impacting positively. So if there are things that we haven't done or that remains to be done, I would single them out so that let's all march towards achieving total viral load suppression in people living with HIV and sustaining their ART care. And then secondly, is that let's go out and provide TPT across board and ensure that persons at risk or those we've started on TPT equally adhere to the TPT. And where feasible, let's provide nutritional support and let's also evaluate the risk of alcohol misuse or the level of alcohol misuse and provide the appropriate counseling to the patients with those risk factors. And third, last but not the least, is the issue of enhancing TB case finding. So we need to accelerate finding the missing cases of TB. In so doing, is that we're cutting down the chains of TB transmission. And by finding one case of TB, we are preventing several cases of TB. So there are multiple factors that we need to do. The undiagnosed and unlinked TB patients are another source of infection and reinfection for TB. So, sir, those are some of the things that remain to be done. With regard to pediatric TB, Judith, I don't know which facility you are coming from, but certainly we stand ready to provide technical support to your facility so that you too could be picking up and managing childhood TB most appropriately. Your advice on bringing on and coordinating with the MCH, I think I'll leave it to the chairperson, but it's on firm ground. There was a comment with regard to why is there suboptimal uptake of TPT in clients in private facilities. It's a mixed grill of things. Number one, I think our colleagues providing services and working in the private facilities have been left behind with regard to the newer practices and knowledge on TPT. So provinces and districts will call upon you to go and engage the private practitioners on this important subject matter. Equally, our partners as well step in and provide the technical know-how on this subject matter so that they can reach out more effectively to clients. The other issue is that the provinces, you haven't provided them with TPT. So go on an initiative similar to the mechanism and platform where you're providing them with TB drugs as well as ART to provide them with TPT. We will not eliminate TB if one corner of the country or one section of the population is still not accessing the much needed services. So we have to be as comprehensive as possible and bring about the issues of equity and access across board. So it's a mixed picture. Let's remove the barriers and provide the much needed services. I hope I've covered all the questions that have been brought forth. But I equally saw in the chart why is 3HP not being provided in pregnancy. I think Dr. Tunzizi took it and Dr. Kasese. So I have nothing to add to that. Over to you, Chair.
Right. Thank you so much, Dr. Lungu. In a moment, we are going to transition to talk about the new inclusions in the new guidelines. But before we do that, allow me just to ask for comments from the subject matter experts that we have regarding the presentation and any other points that they would like to raise regarding the same. Particularly of interest was a question that came through from Robert Hambwalula, who asked to say what would be the TPT regimen to be given to a child who is a contact to an XDR patient. Very interesting question. I'll start by asking Dr. Murieta to just give a go to that question, and then later on I'll ask the other subject matter experts to respond on any of the thematic areas of the presentation. Dr. Murieta.
Thanks, David. Good afternoon, everyone. Please confirm you can hear me clearly.
Yes, we can hear you loud and clear, Doc.
Yeah, so not an easy question, that one. But however, in such an instance, and that's what the guidelines give as well, is that the TPT that would be given to such a patient will be dependent on the sensitivity pattern for the patient that they've been exposed to. So, and the current guidance for TPT in MDR or XDR patients or contacts requires that such cases are referred to the clinical expert committee. The clinical expert committee, their role would then be to review the index patient and review the sensitivity profile of the index patient, and therefore then design a preventive therapy for the contacts if indicated and required. That would be my answer to that question. So not easy. There isn't a specific treatment that's recommended at the moment in our guidelines for MDR TB or XDR TB contacts. So I hope that helps.
Thank you so much, Dr. Murieta. And just to add, colleagues, when you are stuck with making such decisions, please don't hesitate to contact the National TB and Leprosy Manager and his team, or you could also ask the experts by using the toll-free line 7040. Right. So there's another question in the chat which I'll throw at Dr.
Singini.
Yes, please, Dr. Chimzizi, please go ahead.
I just want to add from what Dr. Murieta has well elaborated on the question. So mine is just clearly indicating definitely there's no very clear regimen that is you can say that this is the one. But what I just wanted to say that for kind of information that maybe just keep in the picture, because there are quite a number of studies, trials in the pipeline, and some of them maybe results will be coming this year or next year. I would cite a trial called the VQueen and also the TB Champ. This is the one that are looking at the use of levofloxacin on contact of the of MDR patients 6 months, and so this is a placebo-controlled trial. And there is also one trial, the Phoenix trial. They're looking at the 6 months, using 6 months of Delamanid, which is one of the treatment, the drug a second-line drug. We do also have one, what we call Impact for TB phase 4 trial, which is looking at the safety and tolerability of 3-HP or 1-HP in patients on DTG-based regimen. And they are looking at, I think they're looking at women in 20 to 34 weeks of pregnancy, gestation, who are HIV positive. So my message is that maybe soon we'll have a very clear answer when all these studies have been concluded, and then WHO has synthesized this data and then provide update. So I was just building on the issue that Dr. Mohed has stated, that there's no clear to say, okay, but I think she was right to say the DST profile of the patients, but also consultation of the CEC. So that's what I wanted to add, Dr. Sigini.
Thank you so much, Dr. Chimzizi, for that addition. Now, the next one is going through to Dr. Kasese. Someone asked in the conversations to say, do household contacts of TB diagnosed through urine LAM and not gene expert, do they still need TPT? So that one I'll throw it at Dr. Kasese.
Thanks, Dr. Singini, and thanks for the question. Yeah, it's very important. So I'm trying to see the angle from which the question was coming. Someone who was diagnosed with LAM, with urine LAM, is considered to be bacteriologically confirmed TB, and so you know that patient, the contacts should be screened for TB, and if they're found that they do not have any signs and symptoms of TB, they are eligible to receive TPT. And then going further, you know, even if LAM was not considered as bacteriological confirmation, which I think maybe might have been the question, now as a country, we are also, a country program, we are also offering contact tracing, and you know, we want to find out if the for clinically diagnosed cases. And in that case, you know, it's really, really important. As long as there's somebody who has TB, we need to do the contact tracing. Thank you. Hi, Dr. Singini, are you there, or was I, did you hear me?
Yes, yes, Dr. Kasese, I realized I was speaking to muted mic.
Okay,
Right.
okay.
Thank you
Yeah,
so
let me
much.
check the question again. What was the question? What was the question again?
Right. The question was whether or not the patients that were diagnosed, rather contacts to patients that were diagnosed with LAM should be given TPT. And I think from your response, you had adequately tackled that question.
All right. Yes, they should be given. Thanks.
Thank you so much. So the next one, the last question that we'll discuss before I hand over to, before we do the quickly go through the polls and then have Dr. Lungu give us some insights on the new guidelines. There's a question to say, with the new formulations, does it mean that we're doing away with isoniazid as the TPT modality? There was emphasis on, as a country, we are rolling out 3-HP, and that 3-HP is available in all the 10 provinces of the country. But then are we then doing away with INH, Dr. Moti?
Hi, Dr. Singini. Thank you very much for the presentation, and thank you to all the experts and the participants on the call. So ideally, we're not doing away with INH as well. All options for TPT will be provided to the facilities and the provinces. So ideally, what you would do is just look at whichever option is best suited for your patient that is in front of you. You can give shorter regimens to improve adherence for patients who have adherence problems, or you can proceed with the INH. Or if anyone has any side effects or any problems with using INH, you can provide other options that are available. Thank you.
Thank you so much for adequately answering that question, Dr. Muti. So, dear network, at this juncture, I'll just run through the polls that we went through, and then I'll hand over to Dr. Lungu to give us his remarks, and then take us through highlights of the newest TB guidelines that were anticipated. So I'll take you through poll question number 1, and then we'll quickly go through poll question number 2. And then as Dr. Lungu takes us through the remarks, he's going to speak to the responses. So there we have it, network. Poll question number 1. Poll question number 1 read, patient X has been in prison for 1 year and he's attending OPD for complaints of a headache for 3 days. He reports that he usually has these headaches even before his incarceration. HIV test done today is negative, his chest X-ray is normal, and he reports that one of his roommates is on TB treatment based on chest X-ray. What will be the correct action to take on this patient? So that is a very straightforward answer, and I think Dr. Lungu as well as Dr. Chimzizi had discussed this, but we just want to see if learning has occurred. I'll give it 5 seconds for the network to submit their polls, and I'll launch poll question number 2. Right, so we are having a landslide inclination to one of the responses, but we still have 1 or 2 that have opted for other options. Right, so in 3 seconds, I'll be ending the poll and sharing the results and quickly transitioning to the next poll. So 97% thought B was the correct answer, and we had 1 or 2 that still thought option A, D, and E were correct. So I'll stop sharing and move on to the next poll, which is poll question number 2, which reads, Mrs. X is on TLD for 2 years. She is attending her first antenatal clinic at 8 weeks gestational age. She has never been treated for TB before, and she has no other comorbid conditions. The nurse calls you for advice on whether to start TPT. According to the 2019 Latent TB Infections Guidelines, what advice would you give her? There we have it, network. The poll has been launched, and I invite you all to provide the responses and let us know what you think is the correct answer after the discussion and presentation we've had. All right, so I'll just give it 2 more seconds for 1 more person who's struggling with network. Right, okay, there we go. So I'll end the poll and share the results and show you what the voting pattern has been like. So the majority of the participants have transitioned to have D as the correct answer, and I think Dr. Chimzizi's emphasis on this subject has influenced the voting pattern, which is a good thing. We still have a few that think A, start TPT immediately, is the only correct answer, and a few that think C, screen for TB and start TPT in the 2nd trimester as the only correct answer. So there we have it, colleagues. I'll hand over to Dr. Lungu to give us his remarks on this presentation as well as the repo, and then he'll take us through his guidance on the new TB guidelines. Dr. Lungu, over to you.
Yeah, thank you very much, Chairperson, and everyone once again. Indeed, it's been a great afternoon. Greatly appreciated the comments, and also let me also just thank the other presenters or discussants on this who have made it practical and also helped in responding to a number of questions that were brought forth. Indeed, colleagues, it is very evident, there's a lot of supporting evidence, both at global level, at country level, that TPT is highly impactful in preventing TB in the at-risk population. We have done very well with the current coverage of TPT in persons living with HIV. We need to sustain that momentum and equally start to take on other at-risk populations, such as the ones that we highlighted, and equally starting to take up the challenges or challenging forms of TPT in contacts of TB patients. We should not forget the pregnant women. In our scale up of TPT, we should not forget persons accessing healthcare in the private sector. They too need TB preventive therapy. And last but not the least, Chairperson, I would like just to call upon everyone to enhance TB screening in all clients that are accessing TB in our facilities. With that, I would like just to say thank you to everyone. But I think I've seen a comment, if not a question, from Prof. Achambwa. I think he was responding to say, I think the question, just read that. I think the question on TB alarm was trying to clarify whether a contact to someone with extrapulmonary TB requires TPT. Yeah, so I think to answer this question, Prof, if I do a contact to extrapulmonary TB patients, if that person has confirmed TB, therefore we should provide TPT. There are some proportions of patients with extrapulmonary TB who actually have pulmonary disease, especially if you examine their culture, you may grow a positive, you may grow the mycobacterium, and in that regard, they qualify for TB preventive therapy. So at times also in a case like this one, you have to weigh a lot of, you need to go back to the history of that patient and weigh the benefits, and also look at the risk factor of that individual having TB. And where feasible, you could employ upon IGRA or TST, and if it is positive, certainly, then it augments the need for TB preventive therapy in that regard. With that, I would like to thank everyone most sincerely, and happy to provide support to any facility or any districts that may need. Thank you. Have a pleasant day. Bye-bye.
Thank you so much, Dr. Lungu. And Dear Network, I see there's questions in the chat box regarding the updates on the guidelines. Dr. Lungu, are you going to speak to that?
Yeah, updates on the guidelines. Yes, for TB, one, we have developed what we're calling the Consolidated Guidelines, and these guidelines have taken on board both drug-susceptible TB and drug-resistant TB. Essentially, what is new in the TB guidelines, mainly to do with the diagnostic approaches, where LAM this time around has been amplified as a TB diagnostic test. Equally, provided some guidance, critical guidance on use of GeneXpert. And in terms of treatment of drug-susceptible TB, nothing is shifting. But for children, we are employed upon the shorter regimen, essentially still the 4-FDC, but at least for 4 months. And these are children who have only pulmonary disease, lesser severe form, non-severe forms of TB, who will be treated for TB for only 4 months. And then with regard to drug-resistant TB, what is new in the newer guidelines is that we are taking much more on the oral regimen. So that is what is in the newer guidelines. Then with regard to TPT, we are still reviewing what WHO has recommended. Possibly there will not be a major shift. If you look at what WHO has provided, 3HP was already in the 2019 guidelines. What has just shifted is the issue to do with TPT in pregnancy, where now it's much more clear that TPT can be provided across all the 3 trimesters. And what we will be doing is consulting our HIV colleagues for a possibility of an addendum to these TPT guidelines. But not much has shifted. We are in tune with global approaches, and equally the issue of IGRA TST remains optional. So it's not a must. Equally, the chest X-ray remains, use of chest X-ray when providing TPT remains optional. So we should still, where we have the abilities, we can employ a chest X-ray as part of the screening tool. Equally, where it's feasible, we can employ IGRA and TST, but we know that these, in most of the facilities, they are not existent and they can create barriers. So that's what is new in the guidelines. For the TB guidelines, they are available to be shared with all of you. So we will soon be printing the new TB guidelines, which have taken upon a form of a consolidated approach. With that, I sign off. Over to you, Chair.
Just to say, not a very serious issue. You know, we use the term TPT interchangeably to mean TB preventive therapy and TB preventive treatment. WHO prefers that we call it treatment rather than therapy.
Yeah.
So TB preventive treatment is a preferred full name rather than therapy. So not a big issue, but I think it's important to know.
Right. Thank you so much, Dr. Chimzizi, and thank you so much, Dr. Lungu, for those updates on the upcoming guidelines. Colleagues, we've heard what is new in those guidelines, and I think electronic copies of these guidelines should be circulated soon, if they haven't already, by the National TB and Leprosy Program. So look out for that as we wait for the hard copies to be circulated to you all. And I should think there should be some training packages that will be conducted soon and will be guided by the National TB and Leprosy Program. I'd like at this juncture to thank the subject matter experts that joined the call today, Dr. Chimzizi Rehab from the National TB and Leprosy Program, Dr. Nancy Chanda from USAID Zambia, Dr. Monde Myoeta from CIDAS. We have Dr. Lulungwe Muti also from CIDAS. Thank you so much. And I saw various other experts who were on the chat box providing responses. We appreciate you all. From us at the ECHO team, thank you to the coordinator and the IT team that have made this possible. And would like to thank the entire network for having spent time to join us today to discuss this very important subject. At this point, I'd like to wish you well and have a pleasant week. Thanks, and we're signing out.